So, Dr. Barnett-Smith, thank you for taking time. I know today is your day off.
Yes.
And what's better to do, right, on your day?
Absolutely. Can't figure out a better way to spend it than with you.
I was just telling Sean that, Dr. Barnett-Smith is so much fun when she joins us. So, and I really do mean that, by the way.
She's in high demand. We try to get her for our diabetes program as well. So,
well, I really do enjoy our sessions, and thank you for joining us. So this year we try to make this a little bit different. Just pick the topic and then just have the discussion at the primary care level. And we are also sharing some of these videos, just taking this section of the video and then share with our patients. And that's kind of like our goal is to educate our patients. And as you know, we started daily case conferences other than regular case reviews that we have. And this is part of that when we do it on a daily basis and when we go through different patients on a daily basis, certain problems, certain diagnoses come up very frequently. Well, actually, hypertension is probably by far is the number one. And when we were looking for someone to explain us what hypertension is and how we can actually better understand what it is and what we need to do, that's where we ask you, and here we are. And I'll try my best to follow you with your presentation. You can always yell at me if.
Never. Okay, well, thank you so much for that wonderful introduction, Kemal. I am Dr. Barnett-Smith. I am with United Medical Clinic. I work in Bear, Delaware. And I am very happy to speak with you for a few minutes today about hypertension, because as Kemal said, it is something that's very prevalent and we see it all the time. And the more education we get out there, I think it's going to be the better for our population in general. So let's get right into it. Next slide. When people say hypertension, what do they mean? What exactly is that? So hypertension, which you also may hear as high blood pressure, simply put is when your blood pressure is higher than normal. And blood pressure is the amount of pressure that the blood gives when it's pushing against the walls of your arteries. And looking at what an artery is, it's a blood vessel that carries blood from your heart to the other parts of your body. So you can imagine that having a lot of pressure against those arteries is not a great thing. Blood pressure normally will rise and fall throughout the day. So someone can have a higher blood pressure in the morning, and then when they get home after work, their blood pressure is a lot less, and that can vary throughout the day, and that's normal. But if you have an elevated blood pressure for a sustained amount of time, that can cause damage to your heart. And it can also cause health problems if it's not treated. Uncontrolled high blood pressure. So that's blood pressure. Can you go back? Yes, there you go. Uncontrolled blood pressure also puts you at higher risk for diseases that we hear about all the time, like stroke, heart disease, heart attack, kidney failure. Those can be compounded or made worse or put people at risk if they have high blood pressure. Now, next slide. One of the questions that I get asked most often when it comes to looking at blood pressure is, what are the symptoms of having high blood pressure? And unfortunately, for most people, at least in the beginning, they don't have any symptoms. And it's for that reason that high blood pressure is sometimes called the silent killer. It also is a very important fact to illustrate why you need to see a doctor on a regular basis so that you can have your blood pressure checked, because it may be high and you don't know it. Now, some people will experience some symptoms like headaches or nosebleeds, sometimes shortness of breath. But generally, when you have those types of symptoms, that typically means that your blood pressure's been high for some time. Next slide. There are some common factors that put you at risk for high blood pressure, and those are outlined here on the slide. Many of those you've probably heard before, but having a poor diet, having other chronic conditions, family history, not exercising, being overweight, older age, smoking, all those types of factors can make you at higher risk for having high blood pressure. Now, I like this graphic here. This is from the American Heart Association, because it really does help us outline what the different stages of blood pressure are. So as you can see, the green line there is your normal blood pressure. And if you go to your doctor and you get your blood pressure taken, you're usually given a number of something over something. And so those two numbers are your systolic blood pressure and your diastolic blood pressure. The top one is your systolic and the bottom is your diastolic. So looking at this graphic, a normal blood pressure is one that is less than 120 on the top and less than 80 on the bottom. And then those ranges increase, and as they increase, your risk increases. So you can have elevated blood pressure that's not technically high blood pressure or hypertension. And then you have hypertension stage 1, hypertension stage 2, and then in the red line at the bottom there is hypertensive crisis, and that is a medical emergency. So if your blood pressure is higher than 180 on the top or higher than 120 on the bottom, that is a time when you need to consult a healthcare professional immediately. Now, you may be wondering why we are talking about this. Kemal did say earlier that looking at case conferences of our own patients, we see that hypertension is a very common medical problem that patients have. But what does that truly mean? Why is it important that we are discussing this today? And I think that this graphic will help illustrate that. So looking at that first number, 131 billion, that's the average amount each year that high blood pressure costs the United States in healthcare dollars. So looking at an average over a 12-year period, hypertension costs $131 billion. That is a lot of money. I don't know, Kemal, that may not be a lot of money to you, but it's a lot of money to me.
And my yearly income, right?
Yeah. And then we don't have up-to-date pandemic numbers because of everything going on with the pandemic. But in 2019, there were more than 500,000 deaths in the United States that had hypertension as either the primary cause or a contributing cause. And the exact number for that was 516,955 deaths. Just like the 131 billion, that's a lot of deaths. And it can be laid directly at the hands of hypertension. And then looking at that last number, 47% or 116 million adults in the United States have hypertension. Now, some of them are not being treated. Some haven't necessarily admitted that they have hypertension, but that's a lot of people in this country that are dealing with this condition. Let's move to the next slide. So I've painted a somewhat dismal picture in that previous slide. So I just wanted to talk about what we can do to prevent hypertension, to help avoid it, or if you already had it, what can you do to help control it? And these lifestyle factors are in no particular order, but lifestyle is extremely important when it comes to preventing or controlling high blood pressure. So first thing, if you smoke, stop smoking. And I will say that again. If you smoke, stop smoking. And I don't mean that just for high blood pressure, and we're not going to get into a lot of this today, but smoking, when I was in medical school and we were taking tests, a professor said to me one time, if smoking is listed as a possible choice for a cause for a condition, pick it, because 9 times out of 10, smoking is going to be a contributing factor to that condition. So if you're smoking, please stop smoking. Reduce your alcohol or eliminate it completely. If you are not at your ideal body weight, work on losing weight. Learn stress reduction techniques and relaxation methods to help reduce your stress. Lower your salt intake. Try to increase your fruits and vegetables in your diet. And lastly, exercise. And you don't have to have a gym. You don't need to have any elaborate workout routines. Just a pair of tennis shoes and your legs are enough to get you in a 30-minute walk every day, which will do tremendous good for your cardiovascular health.
So I think that was your
yeah, that was my last slide.
It was your last one, but I have a couple questions.
Sure.
So in terms of medication, a lot of people do have different blood pressure readings, right? So, and we do give numbers, and in some cases, someone have high readings, but it may not be high for them. It may be too high for someone else comparing to someone else. So in those cases, how do they make that decision? Like if two friends are comparing, oh, mine is like 145 versus the other person is saying mine is never over 120, and the person with 145 is freaking out. But then they read something because, you know, our people now, they are all doctors, right? So everyone goes to Google and they read and they learn and they become a doctor. So then they don't have to go to their PCPs anymore. They are very opinionated. So what can we tell them?
So I think it is important to have an open line of communication between a provider and the patient, because like you said, not everybody is the same. No two people are going to be alike. No one's going to have the same exact blood pressure as someone else. But when we look at these ranges and the cutoffs, we look at those based on data that shows what puts people at higher risk for long-term damage. We're not just talking about their blood pressure. We're talking about what type of blood pressure puts somebody at risk for doing damage to their kidneys? What about their eyes? What about their heart, their brain? All those things are affected by your blood pressure. So someone may feel fine with a blood pressure of 145/90, but they could be doing damage over time with their blood pressure staying that way for 10, 15 years. And I think that that is the conversation that's important. It's not necessarily about how you feel right now. It's about keeping you healthy for the next 15, 20, 30 years.
Now, one of the other things with the hypertension, it's number one, most frequent diagnosis with patients with COVID. And I think just you were explaining, it's usually not by itself. It doesn't like being lonely. So it does pick up other illnesses together. And it actually causes other illnesses when it's not being taken care of in a timely manner. So how are your patients dealing with this, with COVID time?
So it has been somewhat of a struggle. It's getting better as things have opened up and patients are more comfortable coming to be seen at the office. But in the early part of the pandemic, it was very difficult just to try and get people to get their blood pressure checked. And have their normal health care maintenance done because of fear. And unfortunately, because of the pandemic and the fact that people aren't able to go to the gym or they're not doing the activity that they would normally do, or not going to the office and they're sitting at their desk at home for 14 hours a day, a lot of those lifestyle factors that we talked about, sedentary lifestyle, poor eating, have come into play, and that has led to weight gain. And in many instances, people's blood pressures have either gone up into the range where we feel like they need to be treated, or they will be under less control than they were previously. And so trying to encourage patients to continue to keep their health at the forefront, even during these trying times, has been a goal of myself and my colleagues at United Medical, so that we can give them the best care possible.
So this is from our little research that we had with our COVID patients, Dr. Barron Smith. So it's 66% of our patients who had COVID positives, they had hypertension as one of their diagnoses. So it's so common. And number two that follows this actually is morbid obesity or obesity actually. So it is, it's one of the reasons that we actually wanted to talk about this issue today, is also with the COVID, it becomes almost more difficult. Now, you mentioned that the blood pressure, checking your blood pressure. What's the easiest way to do that? I know it sounds like a little slow question, but I'm just asking that.
Do you mean as far as
how am I going to check that?
The easiest way is to see your doctor on a regular basis, but you can also do it at home. There are blood pressure monitors that you can get at the pharmacy, and they will take accurate blood pressures, and you can keep an eye on that at home and make sure things are trending in the right direction. I generally advise patients, if they're going to do that and check their blood pressure at home, they should bring it in to their provider to have that checked, just to make sure that it is accurate, because all home devices aren't created equally. So we want to make sure that it's giving somebody an accurate reading, making sure it's not reading too low and giving them a false sense of security. But that you can check it pretty much on a daily basis if you wanted to, if you had a home monitor. But the most accurate way, we talked about the easiest way, but the most accurate way is to see your provider. And I do recommend that people come in at least once a year. If they have no medical problems and they're healthy, the best way to keep you that way is through prevention.
And so Dr. Barnett-Smith, you had mentioned about taking it at home. And so I know sometimes patients will say, well, I do take it at home, and at home it's always 120/80, but when I come in here, right, it's 150/90. So sometimes we hear that term, the white coat syndrome. So typically in cases like that, to your point, they should bring in their device so we can make sure that it's accurate. And two, usually you would take it at the beginning of the visit and then again at the end of the visit to see if they've relaxed some and some other things have transpired during that visit to see if it was unusually high at the beginning, correct?
Yes, absolutely. And one of the things that I also talk with my patients about is with white coat hypertension or stress hypertension, the question is, how often are you stressed? Because if your blood pressure is only normal when you're sitting at home with your feet up, how often can you do that? What's it doing if you're sitting in traffic or if you're at work? And because we're looking at what things are like over an average. And if your blood pressure is high on average and only in a normal range when under the best possible conditions, that still may be something that needs to be addressed.
So one of the reasons I was asking the question earlier, with the telemedicine, actually owning one of those blood pressure machines is important because then when there is a telemedicine, then at least we have some reference. So I actually didn't have one until recently, and I actually got one. It's $28. It's inexpensive. So I think even if you don't have hypertension, you should own one of those. People should be checking these more frequently, especially living at the time that we live in. It does require us to be more on telemedicine, unless there is a need for someone to be physically in the office. It's not the best. Like, I don't want my parents to be in the office if they can be taken care of from their home with telemedicine. But at the same time, to help to visit, it would be extremely useful to have daily readings, some statistics that helps the primary care providers. So that's kind of like, I was kind of leaning to that. Now, if you have a couple more minutes.
Sure.
And we don't rehearse these things, and I do repeat this sometimes because when our people are watching this, they think that we kind of talk about these. We don't. Now, hypertension is also a little bit racist, right? Like in terms of being a disease. So it's a racist disease. Like there are so many different things that's bad about hypertension, but it is on top of all that is also racist. Mm-hmm. So in terms of treating hypertension, how does that changes for you with our patient population?
Sure. So as you mentioned, there are racial disparities in hypertension, with non-Hispanic, Black patients having hypertension at a higher rate than other races. And it's also multifactorial. Is it solely race? It may be, but unlikely, because there are other factors that you have to take into consideration. So socioeconomic status, lifestyle, access to care, access to treatment. So there are several factors that are involved in that. But I think one of the things that is so important is trying to level that playing field as much as we can. And I know with our ACO, we try to identify those barriers to treatment and healthcare, and I think that is so important. I also think it's important for us as healthcare providers to meet a patient where they are, meaning that we don't get so bogged down into just treating the numbers, that we treat the patient themselves, because unfortunately, like you said, Kemal, for the you're having a home blood pressure machine for $28. For some patients, that's just not doable. So there are programs. Some insurances will help cover the cost of a blood pressure monitor. So there are things that we can do to assist patients so that we're able to kind of bridge that gap, so that they're not left with more problems, less adequate health care, and then end up doing poorly.
So that's actually, that's a good point, because what we do in these case conferences, Dr. Barnett-Smith, when we are discussing the case with our nurses, we also start to process in some cases, because believe it or not, although they have insurance coverage, there are some patients they have, well, I can give you a number. There are about 20 patients who's homeless. Mm-hmm. There are more than 100 patients who have food insecurity issues. Like, it's not like the healthcare is not a cookie cutter type of approach where not everyone's need is the same. So understanding and learning about the patient is important, individual patient. So we do engage the insurance company and their case managers early on, so then they are actually working with us. And Donna actually is meeting with them. There's a different case conference on a monthly basis that they have, and that does help. And as you said, those insurances, Medicaid, they have a lot of different benefits other than just providing the coverage, including transportation, including other benefits outside of the just healthcare coverage. So, and we are trying to help our patients to reach out to those and learn about those. And actually, it's even this event is one of those efforts. And again, for you to be available on your day off is really important, and I do appreciate that. Thank you so much again. Anything you would like to add?
No, just thank you so much for having me. I always appreciate our talks and the ability to be able to get some information out there. And for those of you watching, check your blood pressure.
Will do. Thank you so much. Bye-bye. Patient hours, and then she's with us right now. And then also we have our Director of Clinical Integration, Donna Gunkel, with us. So I'm going to ask first Donna and then Dr. Belisena to introduce themselves.
Hi, good afternoon, everyone. Again, I'm Donna Gunkel, and I'm the Director of Clinical Integration here at United Medical ACO.
Hi, good afternoon. This is Dr. Belisena. I'm a primary care physician, internal medicine here in Bear, Delaware.
Dr. Belisena, thank you so much for joining us, and also Donna, as usual. Now, we do want to discuss this topic of, and I'll tell you, maybe we want to make sure that we get the most time out of you, so I can save my comments to the later time. But with our Medicare population, urinary incontinence and the fall prevention are the two problems that we are always having issues with. And then many people don't really understand how important this is. And some patients, they are not comfortable bringing this up. And we wanted you to kind of help us with what patients should know, how they can bring this up. Again, this is for our main focus for today is more on the elderly population for Medicare. How can we actually address these issues? And then from the clinical standpoint, how you are actually dealing with these and so on. So if you can kind of maybe explain us what this is, we can start with the urinary leak.
Yeah, so there are many reasons why patients encounter this incontinence, whether they're leaking or whether it's just related to certain activities like coughing or exercise. So mainly when I deal with these issues, it's pretty much on their Medicare wellness exam. However, it also comes up when they are having symptoms like, they say that they're leaking, or when they're coughing, they have a little bit of leak. Or one of the things that I really ask them during a wellness exam is, do they wake up in the middle of the night to urinate? And because to me, that's a safety issue more than anything else. The reason for that is, of course, they're during the evening, they're just because they're sleepy, the area can be dark, it's not well lit, they can fall, trip, and basically break their hip. So that's really a safety concern more than anything else. And then when it comes to the different kinds of urinary incontinence, it really, to them, it's really not an issue. It's basically for the providers to say, okay, because of what you're telling me or what your symptoms are like, then this is the way to go. Whether it be a Kegel's exercise, or whether it be medication, or whether it's just been training, like, okay, before going to bed, let's say, what time do you go to sleep? And they say, okay, maybe 11 o'clock, 10 o'clock. I'd say, okay, so if you sleep at 11, go ahead and maybe last drink should be at 8 o'clock. And then even though if you don't feel like urinating or peeing before going to bed, just go urinate. So then the hope is they won't wake up in the middle of the night to urinate. So that would be how I would address these kinds of situations. And with regards to, there's different kinds. There's stress, there's urgency, there's overflow, and those come with a certain type of diagnosis. And most common cause of incontinence is overactive bladder. And women most commonly will experience this, but of course men can do that. But of course, for men, it's most likely due to prostate issues. And that comes when they're elderly. The other thing with women is when they're too busy taking care of the kids, they hold their urine, or they're working too much, and before they know it, they forget to go to the bathroom. And sometimes that's what happens, and then they cause some incontinence with that. So it's just basically educating these our patients and say, okay, what's the situation? When do you have these problems? And to address those kinds of issues when they come up.
So, Dr. Belsen, do you feel like if the patients are having difficult time to bring these issues up, and then I have the same question in a different way, do you sometimes feel not for you, maybe personally from the clinical side, do you feel like sometimes primary care physicians, maybe they are not bringing this up unless the patient says something?
Well, from my personal experience, it's not a problem for me because that's part of the review of systems. That's part of, I ask, do you have issues with urinating? Is it painful? There's blood, there's pain. And do you urinate? How frequently do you urinate? So that's part of the review of systems. That's, part of the physical exam. And not only that, let's say they come in and they have issues. Let's say they have urinary tract infection. So you want to say, okay, when was the last time you've had an infection? What's the situation? What are your other symptoms? And so I guess with women, for me, it's not a problem. The other thing too, I would maybe on the EMR side, it would probably be helpful sometimes because sometimes I have to look around where the urinary symptoms are, and it's easy. Probably would be on the banner, so then it's right there, and it's a good reminder for us to say, okay, you need to ask these things, especially with the elderly. But that's part of my Medicare wellness when I ask patients.
So from the elderly standpoint, and I say elderly, but this is now 65 and over, the population we are talking about.
Mm-hmm.
I really shouldn't say elderly for 65. So now the overflow, and this is the functional, right? The functional incontinence. So these are the two most common. And now this is the one with the disease related, such as diabetes, and this is just from the age. Now, from the treatment side, Now, what would be the best way to, like, what is your choice of treatment when this happens, either from the overflow or from the functional?
So because the overflow would most likely, never say never, but most common in men because of the prostate, because you're blocking the prostate, right? And so you want to make sure. So of course, a good history, very important, very, very important with good history, because a lot of times it's not clear cut. With incontinence, and sometimes it's just overactive bladder. And then for the neurogenic, of course, that could be like, it could be a spinal cord issue, not most commonly, because for diabetes, it could be many different things, because high sugar itself is a diuretic. So when their sugar's high, they'll be peeing a lot. So one of the things that we really ask with people who have diabetes is, do you wake up at night, and how many times do you wake up? It's nocturia, basically. So that's one of the things that we ask, symptoms that we ask when they follow up with us, because that's a red flag, would say, oh, your sugars aren't controlled. Yeah.
I guess with in some of the cases with the water intake, right? So the timing of that. Now, the other problem is with as the age comes into the equation, the disease like such an Alzheimer. So those patients do have. Actually, one of my family members is going through that problem, and it's challenging, because the problem is that they forget that they eat, or they already drink, and then they start drinking again, and they repeat the activity again and again. How is the treatment options, or what are your suggestions for that population?
A lot of times we give them a trial. There's many medications right now to see if that's going to help. But when we're dealing with Alzheimer's, the way that I think about it is like, when you're training your babies or your kids, when you're toilet training, you have to remind them, like, okay, it's time, make sure, so they're not having accidents. So maybe every 2 hours, every 3 hours, put a timer in. So just, it's a reminder, or if they if they have a cell phone, you could put a timer there. So it's just a reminder. So to me, it's just like potty training when it comes to issues like Alzheimer's. The other thing is, there's Myrbetriq, which is really good. In the past, you could either use both. Some urologists use both Myrbetriq and Vesicare as a combination, and that seems to work out pretty well. And with regards to coverage and side effects, Myrbetriq really is, I think, superior.
One of the things that I see, and I was just talking to Sean earlier, when we do our case conferences, we do deal with patients who have complications and high complex chronic illnesses. And one of the big problems that we see is the issue of these patients not actually getting enough support at home. And they're not in assisted living, they're not in a nursing home situation, they're home. And unfortunately, part of our culture here is that we have we don't have the same support. Like, I know, like, you are from Philippines, I'm from Turkey, and the dealing with our elderly population is different. So we do have more family support than here. So I think one of the problems that we are kind of seeing again and again is if the patient is not bringing this up. I think I do want to spend a little bit of time on this patient experience issue. From the patient experience side, like, we do have we have this embarrassment. I don't know if it's just me. I have close to 400 providers I work with, and 160 of them, they are in the ACO, 180 maybe. And we still have this embarrassment when we have issues to bring up to our PCPs, our physicians. Now I'm going to be volunteering for this, and I have that problem. So if I have some problem, I'm going to do more Google search before I ask something to Dr. Garcia. So do you think that's part of the problem that patients
It could be, but the way that I present it, it's like, nonchalantly, it's like, oh, do you have headache? Do you have dizzy? Are you lightheaded? Do you have any chest pain, shortness of breath? Do you have problems urinating? Do you pee? Do you pee your pants? Do you, that's like the things that I do. So it's not like I'm intrusive, I'm being degrading to them. It's what I ask them, and it's part of what I do as a provider, as a physician. So it shouldn't be something that's like, oh, she's asking me because whatever. But so it comes out as a natural kind of question and answer situation, rather than more of a, oh, you're doing this or you're doing that. So when I see, I'm talking about me, but so it's not like something that's intrusive when I ask them about those, about urination or about incontinence.
So we were wondering, like, the way the question is phrased, if maybe depending on the way it's asked by the doctor and then the way it's asked in the survey, because that is one of the issues that Kemal is talking about, is our patient engagement. So after patients have like their Medicare wellness visit, they do get a phone call, a survey, like from Humana or from United Healthcare or from Medicare. So the way I'm kind of looking at our book here. The way the survey question reads is, did your doctor discuss bladder control or issues with urine leakage? And kind of across the board, it's low, not just with our patients, but in general, with, like across the board, it's much lower than a lot of the other questions, like, could you see your doctor when you wanted to? That's a much higher number. So we didn't know if you had any thoughts about that and maybe the way it's asked.
I think so. I really do. Because if they mention the word bladder, I don't think it crosses that threshold between what the patient understands as to what the question is being asked.
Right.
Because sometimes when I say those things, they're like, what? What's your question? So they don't even get what I'm asking. So I say, do you pee your pants?
Right.
Or
and that's what I'm wondering is because of the way the question is phrased about bladder control or issues with urine leakage, if they're not hearing that exactly the way that is. So, that's one of the other things that we were looking at is there like a way, and also we're trying to send out some additional emails so patients do become more familiar with this and feel more comfortable about talking to their provider about those,
or just
those
maybe
kinds
like
of things.
Put a parenthesis below that, like examples, maybe, that's kind of things. Because if you say bladder leakage, I don't think they would necessarily think about that in terms of, oh, I'm wetting my pants when I go to the bathroom, or I'm leaking a little bit, or
these are, I think, automated, like because we don't do them. These are put out by Medicare. But certainly we've had conversations with the insurance companies in our monthly meetings, and part of that is they ask us, how do we address this with our patients, and do we have any ideas? So that's a good point. Is you may be asking some of those questions about how often they go and different things like that. And they may not always be relating it to the way the question is worded in the actual survey.
Like, for example, do you wet your pants when you jump, when you do your exercises? So when I ask those questions to that patient, do they necessarily think that it's a bladder issue?
Right.
So they won't probably think about that, but that's what I mean when I ask those questions.
Right. Yeah. Or even the leakage part, or So I do think sometimes it is the semantics, how we
Yeah.
say it or how they're saying it, and
Mhm.
putting that together. So I think part of it too is just making sure that the patients hear those things, that they become comfortable if they're uncomfortable or, as Kemal said, embarrassed about having that discussion with their doctor, but that it is important because one thing can lead to the next. So I know one of the things you had mentioned a few minutes ago was if they get up in the middle of the night, your concern is them falling, and that's like our next topic. So it kind of leads into that, where we're concerned about fall prevention from a variety of perspectives for patients. So sometimes those things do go hand in hand, or they do impact each other.
Well, actually, Donna, what you said is what I was about to just go into, because fall risk and the fall-related injuries is one of the most severe and the costly problem for the elderly population. Now, I was part of the trauma program for St. Francis Hospital in the beginning, so we had to do a lot of statistics, and 50+% of the trauma cases are coming from the fall cases, one-level fall cases. So 50%, a little more than 50%. Now, this, when Dr. Wilson mentioned this night, getting up at night, and how that's linked to the fall risk, it's kind of like extremely, I guess, important from our point that this number, the fall increase, actually did increase. That's about 30% in the last 10, 12 years. Now, as this is increasing, the cost is increasing. But I think the biggest problem even before the cost is healing from this process is a lot more difficult for the elderly. So if they break a bone, for them to heal, it's going to be almost so difficult, right? So now, what can we do for what are the facts about the fall in the older adults, and what can they do? If we can just go through that a little bit.
Sure. So, I did pull out a few statistics out there from the CDC. So each year, millions of older adults, again, we're talking 65 and older, fall, which is about 1 out of every 4 older adults fall. But as you can see here, less than half tell their doctor. So it is one of the things, and I'm sure Dr. Belicena will agree, it's part of that Medicare wellness visit. So one of the other things that's done during that visit is actually a screening about any potential, the potential for current falls or future falls, but also have they fallen recently, and then looking at those kinds of things. So again, what may lead to them falling? It can be, weakness. It can be medications that they're on that cause them to be, as Dr. Belicena said, dizzy or have vision problems, or, a number of other things. It could be the vision problem. It could be foot pain. It could be home hazards. So that's also important to remember, that they want to have, hopefully not clutter, get rid of any items like loose rugs that they could trip over, other things laying on the floor, utilizing bars like around the toilet or the shower, things of that nature, where they may need assistance, in standing from a seated position. Sometimes also making sure when they sit in a chair that it has arms, perhaps, so that they can help push themselves up, or have something to hold on for stability. So again, one of the things that we want them to do is to make sure they are talking to their provider about those kinds of things, so that an assessment can be done. And I'll let Dr. Belicena talk a little bit about that.
Yeah, so part of the physical, or whether they're probably having problems with their back, or having problems with their legs, or just any ambulatory issue. One of the things that I check is when they're lying down and they push on their feet towards me, so that I can feel how much strength they have basically with their thigh muscles, because that's what they use to stand up basically. And that's what I check. But one of the things that's really, I think, very revealing to me is I ask them to sit and I ask them to stand up. A lot of times they need to prop up themselves with their hands. And I said, what if you put your hands on your lap and then stand up for me? And most of the time, or like I want to say between 70% of the elderly, and I'm talking about 75 and up, they have difficulty doing that.
Mm-hmm.
So then, I'll segue to that, but I usually refer them for physical therapy for fall risk and that sort of thing. But really, I try to explain, okay, you need to try to strengthen your core muscles. That way you don't fall, and strengthen your thigh muscles. In women, when I ask them about this, it's funny because I say, when you go to the bathroom, in public, do you sit on the commode or do you squat? So that's a revealing, answer, because when they squat, I notice that they're stronger, like they don't fall easily. Mm-hmm. It's because, they're able to do that. But with men, they don't necessarily do that when they pee. So I find that when they try to balance on one leg, it's a problem. They have difficulty doing that.
I think the main issue, one of the things that we really need to kind of remind ourselves is that I think preparing for those days, those years, now the population, the life expectancy is much higher than where it was 20 years ago, 40 years ago. Now, I think the projection of some of those people, they're like, well, I'm going to die before that age, so I don't have to really prep much. So it's not those anymore, right? So like even today, like when you hear someone who dies at age 75, you feel like that's too young, right? I mean, how many times do we feel that way? And it is. So then I think we need to really prep our population better for these days. So daily exercise is extremely important, and then they just need to walk. Keep them active, keep themselves active, and even with the small weightlifting activities at home, they can easily do that. Now, Dr. Belson, I know you are actually seeing patients, and we are okay if you need to take off.
Thank you.
Well, thank you so much for joining us.
You.
It's extremely important to have you. Thank you.
Bye.
Thank you.
Thank you.